Hello friend, today we will discuss acute medicine. Acute medicine. Today we will discuss acute medicine. So this is a very important chapter in internal medicine. Every student must know details about acute medicine. In the emergency setup, we frequently get patients of various presentation, and the presentation may be patient having severe shortness of breath or tachypnea or hypoxia. Patient may have palpitation or tachycardia, may have shock or hypotension, may have some hypertensive emergency, may be presented with delirium or coma, or patient may present with renal failure. So patient may have multiple various presentation in single or in combination. So what we should do in a primary in the on first approach, we should go for a primary survey. When we attend a patient in the emergency setup, we need to do a primary survey. Need to do primary survey. Primary survey. So what is the primary survey? We have to look at the airway, breathing, circulation, disability, and exposure. So we have to, in the airway, we have to check that the airway is patent or not. So we have to check the patency of the airway, and we have to ensure a patent airway. We may need to introduce a nasopharyngeal tube, or we may need to do tracheostomy to ensure a patent airway. Then we have to assess the breathing of the patient. We have to check the respiratory rate, respiratory depth, pattern of the respiration, for which we may need to percuss or auscult the chest. If there is no respiratory effort, we may treat as respiratory arrest. So in that case, we may need to intubate, or there may be requirement of mechanical ventilation. If there is breathing difficulty, we may need to give high flow oxygen, or giving oxygen by NIV mask. We may need to relieve tension pneumothorax if there is any. Then we have to check the circulation. For circulation, we need to check the pulse, blood pressure. Then we need to check the capillary refill time. So, and we must need to auscult cardiac sound for S1, S2, and any other abnormal cardiac sound present or not. So, by checking pulse, blood pressure, JVP, capillary refill time, cardiac sound, and we have to look for evidence of any hemorrhage. So, by which we can detect a patient is on shock or not, or a patient is having some hypertensive emergency, or a patient having arrhythmia, or patient having cardiac arrest. So from checking pulse, blood pressure, peripheral capillary refill time, and JVP, cardiac sound, we can decide patient having cardiac arrest, or patient is in shock, or patient having some hypertensive emergency. So circulation assessment is very important in a primary survey of a critically ill patient. Then we have to look for the disability. For disability, we have to check the either GCS. If there is enough time, we can check the GCS, or we can look for ABPU, that is alertness and or respond to voice, or respond to painful stimuli, or unresponsive. So, and we also have to check the pupil, the size of the pupil, reaction of the pupil to light, the equality of the pupil, so from which we can detect the disability of the patient. Then we have to exposure, we have to detect exposure of the patient. The patient may have exposed to hypothermia, so we have to check any exposure of the patient to any event. So we have to detect that event and we have to remove that event. So that is exposure. So on primary survey, we have to check airway, we have to check breathing, we have to check circulation, we have to check disability and exposure. At the same time, we have to take history from the relatives or from the surroundings, and we have to look for evidence of drug overdose or suicidal attempt, or is there any history of the trauma or past history or any history of comorbidity like diabetes mellitus, bronchial asthma, COPD, history of alcohol or opioid or drug abuse. We have to take the history at the same time of the primary survey and briefly, and we also have to take the medication history and history of allergy. So by taking a brief history at the same time assessment of the airway, breathing, circulation and disability and exposure is the thumb rule in treating any critically ill patient in the emergency setup. Now we will discuss one by one the presentation. The presenting problem, we will discuss the presenting problem one by one. So, firstly we will discuss chest pain. A patient may have chest pain. The presentation may be chest pain, and we must have bear in mind that chest pain may be central or may be peripheral. What are the causes of central chest pain? Among the cardiac causes, myocardial ischemia, myocardial infarction, myocarditis, pericarditis, mitral valve prolapse is important. Aortic dissection, aortic aneurysm can have chest pain. Then there are some esophageal causes like esophagitis, esophageal spasm, Mallory-Weiss syndrome, esophageal perforation, which is also known as void hub syndrome. So this is an important cause of chest pain. Pulmonary embolism can have severe central chest pain. Then there are some mediastinal cause like mediastinal malignancy can lead to have some central chest pain. Anxiety and emotion is an important cause of central chest pain. So what are the central cause of chest pain? There are some cardiac cause, aortic cause, esophageal causes, pulmonary embolism, mediastinal, anxiety and emotion. And there are some peripheral causes of chest pain like due to lung cause like pneumonia, pneumothorax, pulmonary infarct, malignancy, tuberculosis, connective tissue disease. Musculoskeletal system, osteoarthritis, rib fracture, acute vertebral fracture, costochondritis like Tisch syndrome, intercostal muscle injury, epidemic myalgia. There are some neurological causes of chest pain like prolapsed intervertebral disc, herpes zoster, thoracic outlet syndrome. So how we can differentiate a cardiac with non-cardiac chest pain? This is from Davidson, that there are some causes cardiac ischemic chest pain, non-cardiac chest pain. So usually cardiac chest pain is central in origin and diffuse in nature. There may be radiation of the pain to jaw, neck, shoulder and arm, or sometimes to the back. It is characterized by tight, squeezing, choking in nature, precipitated by exertion and or emotion. It is relieved by rest or quick response to nitrate. It may be associated with breathlessness. So central chest pain is diffuse. It is crushing, squeezing or choking in nature. It is precipitated by anxiety or exertion. It may have some radiation to different site. It may be associated with some breathlessness, sympathetic or parasympathetic symptoms like nausea, vomiting, sweating, or fear of impending death. it is usually relieved by rest or quick response to nitrate. On the other hand, non-cardiac peripheral chest pain, that is peripheral, localized, no radiation, is sharp, stabbing or scratching in nature. It is not relieved by rest, but it may be provoked by posture, respiration or palpation. It has no or slow response to nitrate. It may be associated with some other symptoms of respiratory system, gastrointestinal system, locomotor or psychological system. So that is very different from the central cardiac chest pain. So there is a question, troponin I is specific for myocardial infarction or not? Troponin I may be raised due to different causes. There are some cardiorespiratory causes for raised troponin, and there are some non-cardiorespiratory causes. Among the cardiorespiratory causes, pulmonary embolism, acute pulmonary edema, tachyarrhythmia, myocarditis, myopericarditis, aortic dissection, cardiac trauma, cardiac surgery is important. Among the non-cardiorespiratory causes, prolonged hypotension, severe sepsis, severe burns, stroke, subarachnoid hemorrhage, end-stage renal failure may lead to have raised troponin. So end-stage renal failure, subarachnoid hemorrhage, stroke, severe burns or sepsis, and prolonged hypotension can lead to have raised troponin other than acute coronary syndrome. Now, a patient may have breathlessness on acute presentation, and there are some differential diagnoses for acute breathlessness. So, breathlessness may be due to pulmonary edema, massive pulmonary embolus, acute severe asthma, acute exacerbation of COPD, pneumonia, metabolic acidosis, and psychogenic. Pulmonary edema, it is due to fluid overload in the lung, may be due to heart failure, or may be due to renal failure or any other fluid overload stages. So pulmonary edema, a patient of pulmonary edema may have chest pain, palpitation, orthopnea, that is patient have shortness of breath on lying posture, and may have some cardiac disease, history of old MI or history of chest pain. Patient will present on general examination and systemic examination. We will find patient having respiratory distress. Patient may have central cyanosis, raised JVP, increased sweating, cool extremity, and on lung auscultation there will be basal crepes. On chest X-ray, there will be cardiomegaly and may be associated with pleural effusion, and there may be bat's wing appearance, that is the opacity radiating from both hilum. So that will give rise to bat wings appearance on chest X-ray. And on ABG we will get features of type 1 respiratory failure, that is there will be hypoxia and there will be reduced carbon dioxide. On ECG, patient may have sinus tachycardia, arrhythmia or features of cardiac ischemia. There may be ST changes on ECG. So evidence of heart disease along with sinus tachycardia and arrhythmia may be on ECG findings, and on X-ray cardiomegaly, effusion or batwing appearance, on type 1 respiratory failure on EBG, and on sign there will be raised JVP, central cyanosis, cool periphery and basal crepes. And on history, chest pain, palpitation, orthopnea and cardiac history will be there in case of pulmonary edema. And what is the history of massive pulmonary embolus? Massive pulmonary embolus may have some risk factor which like DVT and prolonged immobilization, or there may be some history of drugs like oral contraceptive pill or something, or patient may have history of thromboembolic disease. So patient will present suddenly chest pain, pleurisy, syncope, dizziness. And patient have some sign like central cyanosis, raised JVP, absence of signs in the lung base. Lung may be clear, but patient may lead to have shock manifested by hypotension and tachycardia. On chest X-ray may be normal. There may be prominent hilar vessels and oligamic lung field. There will be type 1 features of type 1 respiratory failure on ABG, and there on ECG there may be sinus tachycardia, right bundle branch broke, S1Q3T3 pattern, that is S large SOF in lead 1, and in lead 3 there may be Q and T inversion. So that is S1Q3T3 pattern, and there may be ST changes from V1 to V4. So that is the ECG picture of massive pulmonary embolus. Acute severe bronchial asthma. Patient have history of bronchial asthma with history of asthma medication. Patient will present with shortness of breath with wheeze. There will be sound of wheeze in the lungs, and on sign patient may have tachycardia, passus paradoxus, that is the paradoxical fall of BP during inspiration. There may be cyanosis at the late stage. JVP may not be increased, and there will be wheeze on auscultation. And on X-ray there will be hyperinflation unless it is complicated by pneumothorax. On ABG there will be hypoxia, and there will be low partial pressure of carbon dioxide. And when there is raised carbon dioxide, we have to think that it is a very severe bronchial asthma or life-threatening bronchial asthma. If carbon dioxide concentration is high in ABG, if it leads to type 2 respiratory failure, is very dangerous in case of acute severe bronchial asthma. So on ECG, patient may have sinus tachycardia. Bradycardia is a very bad sign for acute severe bronchial asthma. Patient may have acute exacerbation of COPD, previous episode of history of smoking, and patient may present with drowsiness and type 2 respiratory failure. Patient may have cyanosis, hypoxia, and there will be poor air entry, and patient may have evidence of carbon dioxide retention like flapping tremor, bounding pulse. There may be hyperinflation on the chest X-ray. There may be hyperinflation of the lung field, and there will be tubular heart. It may be complicated by pneumothorax, and patient may have evidence of type 2 respiratory failure, like there will be low oxygen but high carbon dioxide on ABG, and on ECG we may get ECG may be normal, or there may be signs of right ventricular strain, that is patient may have RBB or with right axis deviation. So pneumonia can lead to have shortness of breath. A patient may have fever. Fever is very important for pneumonia, with chills and rigor. So pneumonia patient have chills and rigors. So there will be productive cough and pleurisy, that is the pleuritic chest pain patient may have. So on a sign, patient will be febrile. Patient may be drowsy or delirium. There may be pleural rub or consolidation, that is evident by increased bronchial breath sound. With there may be crepitation at the resolving stage, and patient may have cyanosis at the if the pneumonia is severe. So on chest X-ray there will be pneumonic consolidation. There will be ER bronchogram. So ER bronchogram is a very important sign of pneumonic consolidation, ER bronchogram. So within the bronchogram there will be some within the consolidation, within the white opacity there will be some black opacity, that is ER bronchogram, that is the pneumonic consolidation. and on ABG, patient will have type 1 respiratory failure, low oxygen, low carbon dioxide. But if the pneumonia is severe, then that can lead to type 2 respiratory failure, evident by high carbon dioxide. So on ECG, patient may have tachycardia due to fever. The metabolic acidosis is an important cause of shortness of breath. There will be history of diabetes mellitus, renal disease, aspirin or ethynyl glycol overdose. On sign, there will be ketone smell on breathing. Patient may have hyperventilation. There may be no sign of heart failure, or there may be no sign of lung disease. Patient may have dehydration or ear hunger. So patient having ear hunger, patient having sign of dehydration or vomiting, patient having ketone smell, patient having hyperventilation, but on lung auscultation, lung field is clear, chest X-ray is normal, ABG is having features of type 1 respiratory failure or sometimes normal. So, or there may be acidosis. Here on ABG, we will get metabolic acidosis. So there will be low bicarbonate. There will be low bicarbonate on ABG. So on ABG will be can be a diagnostic clue to metabolic acidosis, and patient history, previous history of diabetes, renal disease, aspirin poisoning or ethynyl or alcohol overdose history may give to a clue of metabolic acidosis. Psychogenic previous episodes of digital paresthesia and may give to a diagnosis of psychogenic. Actually, it is a diagnosis of exclusion. We have to exclude other causes of shortness of breath. Then, based on the circumstances, we can lead to a diagnosis of psychogenic cause of acute breathlessness. Patient will have no cyanosis, no heart or lung sign, but there may be carpopedal spasm due to hyperventilation. Hyperventilation will lead to low carbon dioxide and low calcium in the blood, lead to carpopedal spasm. Chest X-ray will be normal. There in ABG, we may get partial pressure of oxygen is normal, but there is severe due to hyperventilation. Patient may have very reduced amount of carbon dioxide. So very reduced amount of carbon dioxide may lead to metabolic, or that may lead to respiratory alkalosis. So these are the causes of, these may be clinical features of acute breathlessness in a clinical setting. There is another cause, angina equivalent. Sometimes for myocardial infarction, breathlessness is the feature, not the chest pain. Breathlessness is feature of, if breathlessness is the dominant feature of myocardial infarction, then it is called angina equivalent. When patient having wheeze due to heart causes, that is called cardiac asthma. It is not bronchial asthma. Heart failure lead to wheezing, it is called cardiac asthma, not bronchial asthma. So another two things we need to remember: in respiratory acidosis, it takes the kidney about 12 hours to compensate and raising the bicarbonate level. So patient having respiratory acidosis, kidney will try to compensate it by raising bicarbonate, but it takes at least 12 hours. We need to remember that one. Normal partial pressure of oxygen may be misleading normal in carbon monoxide poisoning. So in carbon monoxide poisoning, there may be on pulse oximeter we may get oxygen saturation is normal, but we need to do ABG to diagnose it is a case of acidosis, that is the carbon monoxide poisoning. So in carbon monoxide poisoning, we need to do ABG, arterial blood gas analysis. So there are some admission criteria in critical patient. When patient we have ward, we have HDU, and we have ICU. In the ward, when intermittent observation and follow-up is required, that is ward. But when patient needs monitoring of the blood pressure, monitoring of the central venous pressure, fluid balance, or GCS recording, or patient need one organ support, then we need HDU. But when the patient need two or more organ support, that is the inotropic support or oxygen support or intravenous fluid, two or more support, along with patient may need to undergo endotracheal intubation or mechanical ventilation. When there is risk of mechanical ventilation, then we place the patient in ICU. So this is the criteria for admission of the patient to ward, HDU, and ICU. What is hypoxia? Sometimes we get in by pulse oximeter patient having low oxygen. So SpO2 is normal, SpO2 is reduced. So we can call it hypoxia. Hypoxia is reduced level of oxygen at the tissue. Reduced level of oxygen at the tissue is hypoxia. So lower arterial partial pressure of oxygen to the tissue is hypoxia. Hypoxia may be central cause, may be peripheral causes. So there is another term, relative hypoxia. That is it is the comparison between the observed partial arterial pressure of oxygen that which might be expected for a given fraction of inspired oxygen. So sometimes relative hypoxia means patient having a inspired oxygen and but good inspired oxygen, but there is hypoxia in the blood. So that is called relative hypoxia. But the oxygen supplementation, that is the fraction of inspired oxygen, that is normal. So that is called relative hypoxia. There are common causes of hypoxia in a hospitalized patient. Hypoxia due to shunt, lung collapse, consolidation, alveolar hemorrhage, interstitial edema, interstitial infiltration, silent aspiration of gastric content. These are the causes due to shunt. And there are some causes due to ventilation perfusion mismatch, which occurs in pulmonary embolism, acute exacerbation of asthma, or acute exacerbation of COPD. And hypoxia due to hypoventilation, that is due to respiratory depression due to some drugs like opioid, or severe COPD, or patient having some neuromuscular disease like myasthenia gravis leading to respiratory failure or depression. So patient may have hypoxia due to shunt like collapse, consolidation, interstitial edema, or aspiration. Hypoxia due to ventilation perfusion mismatch, that is asthma, COPD, and embolism. Hypoxia due to hypoventilation, that is due to respiratory depression in opioid poisoning or myasthenia gravis or severe COPD. So these are the causes of hypoxia. So we sometimes we give oxygen therapy, but what are the indication of oxygen therapy? Oxygen should be prescribed to achieve a target saturation of 94 to 98% for most critically unwell patients. But we have to remember that for those who have chronic type 2 respiratory failure like COPD, we maintain oxygen saturation from 88 to 92%, not more than that, because hypercapnia is a stimulator for respiratory drive. So there are two stimulators for respiratory increased respiration. One is hypoxia. Number 2 is hypercapnia. So we must have to maintain some who are chronic who have chronic hypercapnia, that is like COPD. We have to maintain slight hypoxia to have some respiratory drive. To have some respiratory drive, we have to maintain hypoxia. We have to them who have chronic hypercapnia. We have chronic hypercapnia. We have to maintain mild hypoxia. So that is very important note. Hypotension and cardiac output. There are two types of cardiac failure. That is high output cardiac failure and low output cardiac failure. Sometimes patient lead to hypotension or shock. So there are two types of cardiac failure: high output cardiac failure, low output cardiac failure. In case of the low output cardiac failure, the patient will be cold periphery, and there will be peripheral cyanosis and raised JVP, raised venous pressure. And on the other hand, high output cardiac failure means patient have warm periphery, patient have high volume or strong pulse volume or hyperdynamic circulation, low pulse pressure, and pulsatile head movement. So the patient will high cardiac output failure, there will be hyperdynamic circulation. Low cardiac output failure, there will be low blood pressure. So sepsis, allergic reaction or anaphylaxis, drug overdose like some antihypertensive drug, acidosis like diabetic acidosis, lactic acidosis, thyrotoxicosis and beriberi. Sepsis, anaphylaxis or allergy, drug overdose, diabetic ketoacidosis, thyrotoxicosis or beriberi can lead to high output cardiac failure. On the other hand, bleeding, aortic stenosis, dysarrhythmia, obstructive pulmonary disease, pulmonary embolism, cardiac tamponade, severe bronchial asthma, chronic heart failure can lead to low output cardiac failure. So now I am going to discuss bronchial asthma. So bronchial asthma is a very important cause of shortness of breath in a outpatient department. So what are the differentials of acute severe bronchial asthma? Patient may have acute infective exacerbation of COPD. It may be a cause of pulmonary edema, upper respiratory tract obstruction, pulmonary embolism, and anaphylaxis. So these should be differentials of acute severe bronchial asthma in a emergency setup. So there are two types of severe bronchial asthma in emergency setup. One is acute severe bronchial asthma, another one is life-threatening bronchial asthma. When patient is unable to complete sentences in one breath, when the respiratory rate is more than or equal to 25 per minute, when pulse rate more than or equal to 110 beat per minute, when peak expiratory flow is 30 to 50% of predicted or best, then we can tell it patient having severe bronchial asthma. But when on peak flow meter, the peak expiratory flow rate less than 33% of predicted or best, when there is silent chest, there is cyanosis, feeble respiratory effort, when there is arrhythmia or hypotension, patient is exhausted, confused or in coma, patient having some sorts of hypercapnia or patient leading to type 2 respiratory failure with hypoxia or arterial oxygen saturation more than 92%, we can tell it patient is having life-threatening bronchial asthma. So what are the measures of life-threatening bronchial asthma? We have to nebulize the patient with salbutamol or terbutaline we have to give high flow oxygen. We may give ipratropium, nebulization with ipratropium, and we have to give hydrocortisone intravenous or oral prednisolone, hydrocortisone or oral prednisolone. So we have to give steroid, we have to give nebulize, and we have to give oxygen. So we have to give high flow oxygen to keep a partial pressure of arterial oxygen more than 94% to 98%. We have to nebulize the patient with salbutamol or tarbutaline. We have to nebulize the patient with ipratropium, and we have to give steroid like hydrocortisone or prednisolone 40 to 60 milligram orally. Then we have to reassess frequently. If there is good response, we can send the patient home. But if their response is not good, we have to repeat nebulization. And but even if the response is not good, despite giving ipratropium nebulization or oxygen, then we have to think of giving MAXSALP, that is the magnesium sulfate, 1.2 to 2 gram over IV over 20 minutes. 1.2 to 2 gram IV over 20 minutes if patient having very poor response to nebulization and oxygen and steroid. So if the patient is improving, then we have to give a short course steroid for next 5 to 7 days, and we have to give nebulization to the patient. But if the patient is not improving, we have to take the patient in intensive care unit, because patient may lead to have respiratory failure or respiratory arrest, in which cases patient may need to undergo mechanical ventilation. So we have to shift the patient to ICU. So what is the management of COPD? Chronic obstructive pulmonary disease. Here we have to nebulize the patient with salbutamol and ipratropium. We have to give low flow oxygen, not high flow oxygen, and we have to maintain saturation from 88 to 92%. We can give steroid to the patient like IV hydrocortisone 200 mg, oral prednisolone 30 mg OD for 5 to 7 days. We have to give oral or IV antibiotic. To usually COPD have some sorts of chronic infection in the lung, so amoxicillin or clarithromycin or doxycycline may be antibiotic of choice to the patient. We have to give chest physiotherapy to remove the chest congestion. If no response to the nebulization or steroid, we may give IV aminophylline or oral aminophylline. So if despite all the medicine, if there is no response, we can give NIV to the patient, or we can give non-invasive positive pressure ventilation, that is NIPPV, non-invasive positive pressure ventilation. If the respiratory rate more than 30, if the patient having respiratory acidosis and respiratory rate more than 30 despite optimization of the treatment, then we have to consider non-invasive positive pressure ventilation. So consider a respiratory stimulant drug, that is the doxapram, 1.5 to 4 milligram oral or IV, who are not suitable for mechanical ventilation. So doxapram is a respiratory stimulant, is a drug of respiratory stimulant who are not suitable for mechanical ventilation. We can give doxapram 1.4 to 4 milligram. That is, who have agitation, confusion, tachycardia, nausea. It is a short-term measure, and if it is given, if NIV is not available. Usually, in case of COPD patient, we don't consider mechanical ventilation, but we have to consider mechanical ventilation intubation if there is severe respiratory acidosis, that is pH is less than 7.26 and partial pressure of carbon dioxide is rising despite non-invasive positive pressure ventilation. Despite non-invasive positive pressure ventilation, if patient having severe respiratory acidosis and partial pressure of carbon dioxide is rising despite all the measures, then we can consider intubation and mechanical ventilation. There is another very severe presentation, that is pneumothorax. In case of the pneumothorax, we tell it that chest auscultation, that patient will have hyperresonant silent chest. Hyperresonant silent chest. So on auscultation, chest will be silent, but on percussion, it will be hyperresonant. So hyperresonant auscultation is silent. On auscultation, it is silent. On percussion, it is hyperresonant. So hyperresonant silent chest is a clinical findings, bedside findings in a patient of pneumothorax. Patient will have respiratory distress. The patient will have respiratory distress, tachycardia, hypotension, and raised JVP. There may be trachea may be deviated away from the side of pneumothorax. There will be increased percussion note and reduced breath sound on the apex side. So that is the hyperresonant silent chest. So in case of the hyperresonant silent chest, we have to do a chest X-ray, and if the rim of ear is more than 2 rim of ear is more than rim of ear if the rim of ear is more than 2 centimeter, rim of ear is more than 2 centimeter on the chest X-ray, then we have to if it is yes, then if the aspiration is successful or not, we have to, if aspiration is successful, we can treat him in OPD. But if the aspiration is not successful, we may need to go chest drain. So primary pneumothorax or second, firstly we have to think it is primary pneumothorax or secondary pneumothorax. Patient have a shortness of breath and rim of ear more than 2 centimeter. So firstly we have to go for aspiration, then chest drain. In case of secondary pneumothorax, we have to, if the rim is more than 2 centimeter on chest X-ray, we should think of chest drain. And then if it is failed, then we have to think for aspiration. So secondary pneumothorax is better managed by chest drain. Primary pneumothorax is better managed by aspiration than chest drain. So what are the causes of pneumothorax? It may be spontaneous. It may be due to some chronic lung disease like asthma, COPD, cystic fibrosis, lung fibrosis, sarcoidosis. It may be due to infection, pulmonary tuberculosis, pneumonia, lung abscess. It may be some traumatic causes like iatrogenic, sibilant insertion, pleural aspiration, percutaneous liver biopsy, positive pressure ventilation. Carcinoma or connective tissue disease like Marfan syndrome or Ehlers-Danlos syndrome may lead to have pneumothorax. Pneumonia is the consolidation of the lung due to some infection. Common organisms are Streptococcus pneumoniae, Haemophilus influenza, Mycoplasma pneumoniae, Staphylococcus aureus, Legionella, gram-negative bacilli, and some viruses like influenza. So on the chest X-ray we will get some consolidation, ear bronchogram. There may be hypoxia or type 1 respiratory failure on APG. There may be some, and there may be patient may be confused, and patient may, the curve 65 may be high, more than 2. So there may be positive blood culture, sputum culture, and urine for pneumococcal antigen usually checked for Legionella. We may take throat swab to isolate infection. We may undergo bronchoscopy or bronchoalveolar lavage to find out infection in immunocompromised patient. So what are the common complications of pneumonia? Common complications of pneumonia: there may be effusion, lung abscess or empyema, lead to respiratory failure. That infection may go to blood and lead to septicemia. The infection may spread to heart, leading to pericarditis, myocarditis. It may lead to cholestatic jaundice or acute kidney injury. So, lung infection can lead to lung abscess, empyema, respiratory failure, effusion. Then it will spread to blood, pericarditis, myocarditis, acute kidney injury or cholestatic jaundice in the liver. So here here we can see there is a right upper lobe consolidation, and where we can get ear bronchogram, and this is a bilateral bronchopneumonia. Both lung fields are hazy, and there are patchy opacity on the both lung field. So this is bronchopneumonia, not just consolidation. This is bronchopneumonia. So pneumonia. So this is CAF65 is a indicator by which we can think the patient will be treated at OPD or ward or ICU. If patient, there will be 5 criteria: confusion, urea greater than 7 millimole per liter, respiratory rate more than 30, blood pressure less than 90, systolic blood pressure or diastolic blood pressure less than 60, age more than 65. If patient having 3 or more point, patient should be managed in ICU. If the point is 2, patient may need short stay hospital treatment or supervised in outdoor treatment. And those who have 1 or 0 score, they will be treated at home. So CAF65 is a very important feature of pneumonia. Another feature is how we will treat a patient of pneumonia. If the patient is hypoxic, we have to give high flow oxygen, and we have to give IV antibiotic. So there are some guidelines of giving antibiotic. We have to think of giving antibiotic to the patient as per protocol. So now COVID is usually causes pneumonia. So COVID is a very important cause of pneumonia, and it can lead to severe respiratory distress and pneumonia, and may lead to death. So what are the investigation findings in a patient of COVID pneumonia? In CBC we will get lymphopenia. Chest X-ray we may get consolidation, usually bilateral, lower lobe peripheral consolidation is very common in case of chest X-ray. And on CT scan we will get bilateral ground glass opacities. Mostly peripheral basal bilateral ground glass opacity. So that is very important finding, CT scan finding in a patient of COVID. There will be CRP will be very high, D-dimer ferritin may be high, there may be proteinuria on urinary, kidney and liver function may be abnormal, there may be acidosis, blood culture, sputum culture may be positive due to superadded infection, there may be raised troponin I due to MI or associated myocarditis, there may be cardiomyopathy on echo. So this is the lab findings in a patient of COVID-19. COVID-19 patient usually have some complication like pneumonia, acute respiratory distress syndrome, disseminated intravascular coagulation, shock, myocardial infarction, myocarditis, arrhythmia, acute kidney injury, ischemic stroke, encephalitis, myasthenia gravis, multiple organ failure. What is the treatment of COVID-19? It may be treated at home, oxygen therapy, low molecular weight heparin, those who have chance of thrombosis, or those who have raised D-dimer or lung infiltration, they can have low molecular weight heparin. Dexamethasone may be given to a patient of hypoxia or ventilator. There are some antiviral like remdesivir, favipiravir to treat a patient of COVID-19. There are some biologics like tocilizumab or convalescent plasma may be given to the very critically ill patient. Vaccine protects to some extent, but it is not 100% protective. There is a condition, acute respiratory distress syndrome. This is a very alarming condition in a very emergency situation. So what is acute respiratory distress syndrome? As per Berlin definition, there will be sudden onset or new onset of respiratory distress within 1 week of a known clinical insult. So there will be history of a known clinical insult within a week. Like there may be history of 5 days fever, there may be history of burn 5 days ago, there may be history of aspiration 2 to 3 days ago, and patient will have sudden respiratory distress. So on chest X-ray there will be bilateral opacity, but that opacity cannot be fully explained by effusion or lung collapse or nodule. There may be patient will have features of type 1 respiratory failure, not explained by cardiac failure or fluid overload, and echo will be normal, but there will be impaired oxygenation. Patient need very high flow oxygen. Patient need very high flow oxygen. So patient will have. So what is the definition? Patient will have new onset or worsening of the respiratory symptoms suddenly, but with a history of a known clinical insult within a week. Patient have a bilateral opacity on the chest X-ray, not explained by effusion, collapse or nodule. Patient have respiratory failure, not explained by cardiac failure or fluid overload, and there is impaired oxygenation. So that is the definition, Berlin definition of acute respiratory distress syndrome. So determining the severity of acute respiratory distress syndrome. So there are three types of acute respiratory distress syndrome. That is mild, moderate, and severe. So it is done by two criteria. It is if a patient, for example, if a patient of partial pressure of arterial oxygen is of 10 kilopascal on 50% oxygen, that is the fractional fraction of inspired oxygen. Inspired oxygen is 0.5, so the ratio will be 20. So there will be ratio of partial pressure of arterial oxygen divided by fraction of inspired oxygen given to the patient. So the ratio, based on the ratio, that is, there will be three criteria: mild, moderate, or severe. If the ratio is 40 to 26.6 kilopascal, that is from 300 to 200 millimeter of mercury, then it is mild. If it is less than 26.6 and down to 13.3 kilopascal, that is from 200 to 100 millimeter mercury, that is moderate. If it is less than 13.3 kilopascal, or that is less than 100 millimeter of mercury, then it is severe acute respiratory distress syndrome. So what are the risk factors of acute respiratory distress syndrome? Like smoke inhalation, burns, near drowning, diabetic ketoacidosis, pregnancy, eclampsia, amniotic fluid embolus, paraquat, heroin, aspirin, acute pancreatitis, disseminated intravascular coagulation, head injury, raised intracranial pressure, fat emboli, transfusion of the blood product, heart and lung bypass, tumor lysis syndrome, pulmonary contusion. So these are the risk factors can lead to sudden onset of the acute respiratory distress syndrome. So what are the major risk factors for acute respiratory distress syndrome? Acute respiratory distress syndrome may lead to sepsis, massive hypovolemic shock, pneumonia, and these are the actually major risk factors. And what I mentioned earlier, that are the other risk factors. So major risk factor is sepsis, massive trauma, hypovolemic shock, pneumonia, gastric aspiration. So there are some definite pathology for here. There is some how the acute respiratory distress syndrome occurs. It is due to protein leakage. Actually, there will be some inflammation and there will be protein leakage to the alveolar space, and patient will have hard lung, lead to impairment of oxygenation. So the lung will be hard due to protein leakage, obviously due to some inflammatory process, lead to acute respiratory distress syndrome. In acute respiratory, what is the treatment? There may need to early intubation, mechanical ventilation. In moderate to severe ARDS, prone position ventilation or ECMO may be required. Low tidal volume, the tidal volume should be low. High PEEP, low tidal volume, high PEEP. There should be high PEEP, low tidal volume. Prone position ventilation, ECMO. So these are the things we need to monitor during mechanical ventilation. We have to avoid fluid overload. We have to maintain circulatory support by dobutamine, enteral feeding, broad spectrum IV antibiotic. We have to prevent venous thromboembolism by low molecular weight heparin, gastric ulcer prevention by prophylactic IV, PPI. Steroid is controversial in case of acute respiratory distress syndrome. So what is respiratory failure? When patient having hypoxia, low or normal carbon dioxide on ABG, then it is called type 1. When patient having hypoxia with high carbon dioxide, then it is called type 2. So hypoxia means partial pressure of arterial oxygen less than 8 kilopascal or 60 millimeter of mercury, low or normal partial pressure of carbon dioxide that is less than 6 kilopascal or 45 millimeter of mercury, that is type 1. Type 2 hypoxia, partial pressure of arterial oxygen less than 8 kilopascal or 60 millimeter of mercury, but raised partial pressure of carbon dioxide that is more than 6 kilopascal or 45 millimeter of mercury, that is type 2. So both are divided into acute and chronic cases. And acute, what are the acute causes of type 1 respiratory failure? That is acute asthma, pulmonary edema, pneumonia, lung collapse, pneumothorax, pulmonary embolus, and ARDS. What are the chronic causes of type 1 respiratory failure? COPD, lung fibrosis, lymphangitic carcinomatosis, right to left shunt. On the other hand, type 2 respiratory failure may have some acute causes and chronic causes. Acute causes of type 2 respiratory failure: acute severe bronchial asthma, acute life-threatening bronchial asthma, acute exacerbation of the COPD, myasthenia gravis, paralysis, narcotic drugs, primary alveolar hypoventilation, flail chest, upper airway obstruction. What are the chronic causes of type 2 respiratory failure? COPD, sleep apnea, skyposcoliosis, myopathy, muscular dystrophy, and ankylosing spondylitis. So these are the causes of chronic causes of type 2 respiratory failure. So what are the measures, assessment and management of acute and chronic type 2 respiratory failure? We have to